I just wondered if anybody had any questions for our amazing panel. Thank you all to our experts and our speakers. It's just a wonderful variety of talks today. Have we got any? Oh, hello. What? Sorry, this is...
I'm going to just sit anywhere. I'll just sit here.
Come and join in here.
Hi, guys.
Yes, that's it.
I feel like the girl group split me.
Oh, you're loved. You are loved. I promise. Have we got any questions? Sue, are you going to talk about screening?
if you could magically have one public health policy, what would it be?
All the doctors, I think.
Well, if you follow me on Twitter, it has to be vaccines, doesn't it?
Okay, vaccines. Fair enough.
So I think we have to get over the misinformation that's gone about, and that goes to all vaccines, because we've seen a drop in HPV vaccines because of misinformation, MMR, and COVID and flu and things like that. And we're still admitting people with COVID and flu having complications because of misinformation. And I think everybody have admitted with COVID who's not been vaccinated said, I thought I didn't need the vaccine.
How do we do the misinformation bit, though, is the next question.
How to do the misinformation? Well, so as part of standard antenatal care, we have a vaccine clinic in our antenatal clinic, so it's next door, so that sends the message that this is part of your standard antenatal care. We talk about it, we tell people, that's fine if you don't want to have it, just let me give you the information and make your own decision, point them to the right. We ask them why they're not, I'm trying to ask them why they're not asking, and counter that misinformation, try and give it to them. And the more we ask it, the first person asking them, they say no, you might not go over, but once 3 or 4 different people have asked them, then I think that helps.
Either doctors?
My message is prevention is better than cure. I think that far too often people are diagnosed with a disease that's potentially preventable. And I think if we put the resources upfront towards prevention, it's cheaper to prevent a cancer than to treat a cancer. Statistics show that it costs 5 times more to treat stage 4 ovarian cancer compared with stage 1. We need to invest in prevention.
Well, and I think I've already said mine. It'd be make sure everyone knows if they've got diabetes or not.
It's the
Food policy? Sugar tax?
I think that's
we've got the MP here, by the way.
Say,
Hopefully a future government
I think before
MP.
we start, promoting any of the drug companies that are currently causing all the weight loss things, we probably ought to leave it there. But, I'd like to hear other people.
Happy to,
Yeah,
as the non-clinician on the non-clinician on the panel. So I mean, there are any number of individual initiatives that would make a big difference to preventative healthcare for women. I think I have to say, as a politician, the kind of resourcing of our health system is probably the single biggest public health intervention that we could make, because behind a lot of the problems that we have been talking about today, and I'm obviously very critical of the the GPs who none of whom I know, but who saw the symptoms of my constituents and didn't do the investigative tests that would have resulted in earlier diagnosis with those terrible outcomes for them. But behind that sits a health system that is under intolerable pressure, where doctors don't have the time with their patients. Doctors are under pressure around the tests that they're commissioning and the costs of those tests. People don't have the kind of access to CPD and training and development, the kind of specialist. I have an amazing GP practice that we've been with for more than 20 years, and they, have managed over time to have GPs who have different specialisms, so you know who to talk to if you're a woman and you want to talk about your reproductive health or your menopause or any of those things. But that isn't the case kind of everywhere. So I think that kind of sitting behind all of this, we have to sort of acknowledge the pressures of our health system and the need to invest in the staff, so that the staff that we have the time and the resources that they need to deliver the best healthcare that they know is possible.
I'm going to get a go as well.
Yeah, I would exactly agree with you. I think investment is one of the things that I talk about a lot, and not just investment in the healthcare system, but investment in research, particularly with those female-dominant conditions that we know are really under-researched. So yeah, more of that.
And I would want equitable access to fertility treatment on the NHS and to end the postcode lottery.
Oh, sorry. About mental health, what would you do?
In terms of mental health, I would tackle the inequalities in data collection. I would focus on diversifying all data collection to include, because at the moment the diagnostic criteria for mental illness, firstly, it's mainly symptomatic diagnosis rather than biological or genetic diagnosis. So rather than blood tests, which we are moving towards, bipolar disorder can be, I believe, diagnosed via blood tests at the moment. But mainly it's symptomatic, so it's basically playing a game of guesswork with your doctor, and one doctor might diagnose you with one condition, another doctor might diagnose you with another, but whether it's genetic or symptomatic or any data collection, the further away from being a straight white man that you are, the less the diagnostic criteria applies to you. So I would change that as a starting point.
Agree with that one. Have we got any other questions? I'm going to take the lady at the back, sorry. That's all right. I shouldn't say lady, should I? Oh, Katie, sorry.
No, cool. Yeah,
I've got my glasses
no,
on,
Lady
sorry.
Katie. No, it's just whatever. Thank you all so much for a really amazing, fascinating afternoon. My question is about culture change in relation to listening to women talk about the health issue that has brought them to a doctor. That has been a running theme through lots of the talks, that women are not properly listened to. And I'm a lawyer, it's something that we see a lot in our practice. The Infected Blood Inquiry report will come out on the 20th of May. And as well as looking at the haemophilia side of things, that's looked at whole blood, which is a massive issue for women. We heard woman after woman after woman talking about having a postpartum hemorrhage, being treated with whole blood transfusion, contracting hepatitis C, going to the doctor, talking about brain fog, tiredness, lots of non-specific problems, and being told, well, you're a new mother, of course you're going to be tired, and not having hepatitis C diagnosed, because they went back and back and back, and the answer that they got from the doctor didn't change, despite the fact that the children were getting older. How does one change the non-listening culture and improve it?
Shall I start?
Panel.
It's been an issue. The Cumberledge report as well on medicines and medical devices with vaginal mesh. All of the excerpts that they put in that report about women just not, sometimes almost being disbelieved.
And maternity scandals.
Yeah, absolutely. I think there are lots of factors to it, certainly from the work that I've done and the interviews that I've done, and I was very keen for the book not to be, totally a doctor bashing exercise. So I spoke to lots and lots of healthcare professionals, and the really big thing that GPs said, that midwives said, that pretty much every healthcare professional I spoke to said was time. 10 minutes is not long enough for a GP to take a full history to really kind of dig into what is going on. So that, I think, is an issue. And, as we've spoken about, the pressures that doctors are under, I think is a really big part of that not listening and where that comes from. I think there is also a sort of cultural issue around the kind of patient-doctor dynamic. Several of the doctors that I spoke to described a how shall I put this? A reluctance among some doctors to admit when they didn't have all of the answers, and that kind of ego thing, and that inability to recognise that medical science is not an exact science. There are things that we don't know. There are things that haven't been properly researched yet. So I don't know whether that is down to medical training or CPD, but speaking to doctors and trainees and healthcare professionals about, acknowledging uncertainty, I think. Certainly, and Rebecca spoke about this earlier, that so much trauma comes from not feeling heard, not feeling listened to. And actually, a lot of the patients that I speak to say, you know, actually, I would much rather my doctor, my GP, or my specialist, or whoever said, I don't know, but how can we work together to figure this out? And for that relationship to be more of a partnership. So, yeah. Anyone else?
I just wanted to say, you know, to keep doing the same thing in expectation of a different result, I think that's been alluded to before, is the definition of insanity. This system hasn't worked. It's failed women time and time again for all sorts of reasons. Lack of time shouldn't be a reason why you have a bad consultation. So maybe we should look at redesigning where women go to. And GPs are under pressure, and I've heard GPs say, I say to my patients, you're only allowed to talk about one symptom because you've only got 10 minutes. Well, one symptom, you can't forensically link things because somebody could be polysymptomatic and it's all pointing to the same thing. But, you know, I've been doing this for 20 years and the needle hasn't shifted one bit. So maybe we need to look at the way the health system is designed. This isn't working. And general practice, medicine has become so sophisticated that I think it's unfair to expect the GP to know about every aspect of medicine in 10 minutes. So I'm afraid, except something changes, these stories are going to carry on.
So I see a lot of women who are denied treatment because they're pregnant. And one of my roles and the roles of maternal medicine specialist is actually to advocate for women and say it's safe. And it's just, it starts with anti-sickness tablets, it starts with painkillers, and there's an education. So I think we've probably got the education wrong in medical school around that, but I think the public perception is that you cannot take it in because you're pregnant, and if you tell somebody to take something, you get this backlash. You're not allowed soft cheese. Well, that's because soft cheese has listeria in it. You should avoid unsafe medications in pregnancy and take safe medications, and if we change that narrative, then I think a lot of women I'm just talking about in pregnancy, would get better care if people understood. And if you worry about any medications in pregnancy, there's a great website called Bumps in Pregnancy. Put your medication in there, it'll give you the advice. But women are excluded from a lot of trials. So the Ebola vaccine trials excluded pregnant women. They all died. They didn't get it. And despite that, we limited COVID vaccines in pregnancy, despite knowing that COVID was similar to flu. So, you know, we need to, as I say, change the narrative.
Just come in really briefly. So I think when we talk about culture, it can seem extremely nebulous and extremely hard to do anything about. So I think there's a question about what are the things that influence and drive a good culture within any environment, but including a clinical environment. And so so I think one thing to say is bad practice is not happening everywhere. So where is the good practice? How can that be codified? How can that be properly understood? How can that be rolled out so that everybody benefits from it? Really hard to do when resources are so stretched and everybody's under so much pressure. But then the second thing that I'd point to is the regulatory regime, because I should have said this at the beginning, I was here to speak on behalf of my constituent today, but I'm not in the health team on the shadow front bench. I'm in the education team, where we are thinking and talking a lot about the reform of Ofsted, because we can see how schools have become too orientated, or they just are, then they're naturally and rationally orientated towards the things against which Ofsted assesses them. And those things do not capture everything that is necessary for a good education and for the best education for every child, particularly around inclusivity. So we are thinking about how do we reorientate the inspection regime so that it includes most of the things that it includes already, but it also includes things that drive our schools to become better in the ways that we want them to become better. And I think the conversation about culture can just get stuck at a kind of how do we help that, unless we think about and understand that culture is not a kind of abstract thing that generates itself from nowhere. It's driven by the frameworks that create that drive the kind of rational decisions that people make in their workplaces. And so going to the source of that is kind of how you make a difference to it.
I'd love to briefly add, I'll try to keep it brief. I was literally sitting up at the back listening to some fantastic speakers, this fantastic panel speak, and it occurred to me that I remember being aged 14, being diagnosed with anorexia, which was the first of all of my mental health conditions that have been diagnosed. And I remember that being then the label that seemed to medically, with every medical professional that I saw at the time, was the cause of all the other problems. And I remember having all these symptoms sort of drilled into me of, this is what's going to happen to you, this is what you're experiencing. And almost it superseded my experience of who I was. And skip ahead to today, and I've recently been having a lot of pains in my lower abdomen, my lower back. I've tried to cause a fuss with numerous GPs, the majority of them being male, just by chance, and it being brushed off. And one scan showed up pneumonia, but that was nothing to do with this, and yet this isn't being taken seriously. And this is causing me more day-to-day issue than the mental health conditions, which when I go to see a GP nowadays, often it's, well, you have anxiety disorder, you have all these other mental health conditions. Are you sure it's not just in your head? Is what I feel. They don't say that literally, but I come away with that sort of internalized stigma of, well, it's nothing, therefore maybe it is in my head. Bringing it back to the science from the mental health research charity that I work for, I'm sure it's not a surprise for everyone here that women are twice as likely, it's definitely more than men, to be diagnosed with anxiety disorder. Yes, mental illness is a dual causality. Research has proven, studies suggest that autonomy in mental health treatment and self-agency rapidly improves recovery rates. And my research personally also suggests that is true. Finally, this has to be, mental health is physical health. Physical health is mental health. People with long-term, lifelong mental illnesses are more likely to die 10 to 20 years earlier than other people, not from the obvious causes like suicide or the slow suicide of anorexia or other eating disorders, but from comorbidities. So it is vital to treat mental health seriously from a far earlier time, and women in particular, not to be brushed off as it's all in your head.
Well, that's a long way to go then, isn't it? But anyway, the fantastic speakers today. Thank you very much for your contribution. Really interesting topics and just broad area of expertise. Thank you all very much, and thank you to the audience and everyone online. And we're going to get a glass of wine.